Yes, I think it's going to ask you guys to approve the recording. Okay.
Hello. So our group is providing a case study over our client. His name is MD, and he is 2 years old. He was referred to us with a feeding difficulty with severe food refusal and oral aversion. However, he prefers drinking. So, in terms of his case history, some preliminary information. The reason for referral was the feeding difficulties and refusal of food and the oral aversion. Chronological age of 2. His primary caregivers are his mother and father. They speak English at home, and the family concerns are potential weight loss and malnutrition due to feeding difficulties. Some background information. His medical team consists of his physician, SLP, and OT. He has not had any previous hospitalizations or surgeries. He only has seasonal allergies, so that shouldn't be a problem in terms of food, and he is not currently taking any medications. In terms of birth history, the mother said that the pregnancy was unremarkable, had no complications during the delivery. His birth weight was 6 pounds and 3 ounces. He does not have any diseases of the nervous, circulatory, respiratory, or skeletal system, and he does not have hearing or visual impairment. Feeding history, the mother uses a combination of breast and bottle feeding with formula, and he has not had any alternative nutrition or hydration. So there is no history of dehydration. There is not currently a history of poor weight gain. The mother states that he is growing very well, although that is a concern for her in the future. The mother has stated that he does gag prior to being fed due to oral aversion. However, he does not have vomiting or gagging after drinking or a wet vocal quality during or after drinking, and he is not in any pain or discomfort during eating or drinking that we are aware of.
So in the clinical swallow evaluation for the oral motor portion of it, his lip strength was determined to be a little weak. He was only able to puff his cheeks for about 3 seconds. He gave us 6 sets of e, ooh in 5 seconds, but the sounds weren't clear or distinct after several models given. He didn't give us a clear, distinct e or ooh lip roundage. The range of movement was typical. Symmetry was typical. However, there was some drooling and an incomplete seal of his lips, both at rest and during pursing. And the diadokinesis of puh was 20 and 10 seconds, but the p was a weak sound, and it was unable to know it was a puh unless you were like looking at him and listening very closely. His jaw strength was we were unable to do this for a full 5 seconds. We were only able he was only able to have the jaw kept down for 3 seconds when it was being pushed against. Coordination, range of movement, and symmetry were all typical, along with the diadokinesis of ya was also very typical. His tongue strength, when pushed from his cheek and against the tongue depressor, were both very weak. They were very easy to move around. Coordination, range of movement, and symmetry of the tongue were typical. The appearance of the tongue was healthy, and diadokinetics were average for ta, ka, and pudika. However, once again, the p sound was weak, and it was determined the t sound was also weak. It wasn't that clear, crisp t, and it was hard to know what he was saying unless you were listening to him and knew what the target was. His face muscle tone strength was typical, at rest, during smile, and when closed eyes tightly, all of that was typical. The dentition in the oral cavity was typical, and his cough was a good strong cough, and respiratory support in the larynx also seemed typical.
Okay, so for the trial swallows portion of the clinical swallow eval, we did some informal and formal testing. Informally, we noticed some observations of MD self-feeding himself some goldfish, and we observed that he used a very vertical chewing pattern, not so much a rotary chewing pattern, for about 5 to 7 bites, and he did some intermittent sucking, and there was some spillage. And then we also saw him take some apple juice through a straw, and that caused some leaking as well. So going into the formal portion, since he is so refusing of a ton of different foods and things, we used some oatmeal from home. So we offered him that, and he turned away from that and cried during that. And so the clinician introduced a very gentle behavioral feeding technique with him. So that she started with a dry spoon, and then after he took that, he got verbal praise, and then he got a turn at a game on his iPad. And so they transitioned from the dry spoon and then added a little bit of an applesauce puree on it. And he took that without any gagging, and he was very cooperative. And so midway during feeding, he started to lean towards the spoon and start to anticipate the bite more. So the therapist then had his caregivers take over, and that worked really well too. He accepted about 4 ounces of this puree using this technique, and we noticed some good bolus formation and transfer. So overall, what we can take from this is that the liquids and purees cause some lateral spillage of his mouth.
Okay, and for instrumental methods, we decided to choose fees to rule out aspiration, and we determined spillage and lingual weakness in the oral mechanism portion of the clinical swallow evaluation. So we chose fees also because we wanted to see if the child had a swallowing disorder. So due to his feeding difficulties and refusing the liquids, in regards to weight loss and lack of malnutrition, this type of instrument will allow us to get more information about his swallow. So we chose this examination because in the pediatric population, or this is appropriate for the pediatric population because the child will not be exposed to the radiation like MBS, and the child does not have to be fully cooperative. So the results that the fees gave us was adequate bolus clearance and airway protection, adequate bolus propulsion, decreased sensation, inadequate lip closure and tongue control. And then the compensatory strategies that we did was to make sure that the child's seated in an upright position. We thickened purees and liquids to decrease bolus flow and increase control of bolus, decrease bolus size by taking a smaller sip or bite, and active motor exercises we did was strengthen and stretching his lips and his tongue to initiate the contraction and relaxation. And then also passive motor exercises, we massaged and provided that passive range of motion for his mandibular.
Okay, and so then for our feeding team plan and recommendations, we recommended therapy strategies for oral motor delay and inversion. So that included the Beckman Oral Motor Intervention Program, and this intervention utilizes assisted movement and stretch flexes to activate muscle contraction, build strength, and improve range of motion in the lips, jaw, tongue, and soft palate. So hopefully that will help increase some of the weakness that we have noted throughout our assessment. Also in this, we would recommend in this consultation to meet with a dietitian and occupational therapy and to consult with them on our findings. And with that, we would want to start offering meals of smooth purees in the seat with distraction and caregiver feeding. And so follow the puree of 6 to 8 ounces with soft chewables and offering chewables at snack time and daycare. And then as the child improves their acceptance of the purees and the soft chewables, remove distractions and begin to introduce new flavors to expand the diet to fruits, vegetables, and proteins. And then it was also recommended to implement a daily multivitamin. And this would be something we would decide on with consultation of the dietitian. But they would like to, we would want to recommend the daily vitamin due to mom's concerns for malnutrition and vitamin deficiency. That is it for our